The next drug I want to talk about is Zongertinib. It's a new kid on the block. It was very recently approved, I want to say a month ago, and it was approved based on the study BMAON Lung 1. This was a phase 1 dose escalation study, so they studied different doses. Patients who were enrolled on the study had HER2 altered cancer, and patients basically received escalating doses of Zongertinib. And the primary endpoint or the main outcome that they looked at in the study was also the objective response rate, similar to the study that we just discussed for TDXD. So as we mentioned in the previous slide, the main efficacy outcome, the main measurement from the study was the objective response rate and the duration of response. So amongst the 71 patients who previously received platinum-based chemotherapy, so got chemotherapy, but no therapy targeting HER2, the objective response rate was 75%. So 75% of the patients had a reduction in the size of the tumor by at least 30%, and 58% of the patients had a duration of response of greater than or equal to 6 months. Interestingly, the study had multiple groups that they looked at, and one of the groups that they looked at were patients who had also previously received HER2 targeted therapy, an antibody drug conjugate. So they had gotten chemo and then also a HER2 therapy. And those patients had an objective response rate of 44%, which means 44% of those patients responded to this. So I find it interesting and very important to remember that this was a group of patients that had received multiple things in the past, and still there was a decent number of patients who responded to Zongertinib or experienced a response to Zongertinib. And 27% of the patients had a duration of response of greater than 6 months. All of this to say that these two therapies that have been approved, they work differently. They have different side effects. But there is a population for both. Zongertinib is an oral therapy. And so the most common side effect you get from Zongertinib was diarrhea in about half the patients and rash in about 1/3 of the patients. There was no ILD. With TDXD, ILD was seen in about 14% of patients. And we worry about that. This study also showed promising CNS efficacy, and we're waiting on more data on that. But TDXD also has a decent CNS efficacy. The thought process is because Zongertinib is a small molecule inhibitor, that there is very good penetration into the brain, and we're hoping to see really good outcomes in patients who have disease in the brain. So nevertheless, these are two therapies that can be used in patients who have HER2 mutated lung cancer. I'm going to spend some time talking about other emerging therapies. The first one that comes to my mind is sevabertinib. This drug was granted priority review by the FDA in 2025. So this study looked at patients with advanced non-small cell lung cancer whose tumors had HER2 or EGFR mutations. They had multiple cohorts in the group. Some patients had never received HER2 targeted therapies. A group of patients never received any systemic therapy, so this was the first drug that they were getting. There were other groups that were pre-treated with HER2 targeted therapies, and there was a group where patients had, significant disease in the brain. So needless to say, most of the patients on this group who had tumors with HER2 mutations, about more than 90% of the patients. And very interestingly and very excitingly, sevabertinib led to very high and comparable objective response rates in patients with HER2 mutated non-small cell lung cancer. So the overall objective response rate was about 60%, and the disease control rate was 81%. And the response was consistent across many subgroups of patients, including those patients who had brain disease. So this is really exciting, and it was granted priority review. So we're hoping to have this drug approved in the near future as well.